So Dewi will moderate the sessions and also introduce the participants for you in 1 minute.
Okay, thank you. And can you see the first slide?
Yes, very clear. Perfect. And yeah, ready to slideshow. Yeah.
Okay, perfect. And I'll also email it to you, Umi.
Thank you.
Thanks, Elaine.
Okay, can we start, Dr. Elaine, for the session?
Yes, yeah.
Also for the host, Pak Dodi, already rely on YouTube ya Pak ya? Okay, thank you. Let we start. Well, ladies and gentlemen, may I have your attention please? Our session is about to begin. Good afternoon from Jakarta. Assalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, I'm Dewi Sinta, the moderator for today. I also would like to greet to the course coordinator of postgraduate training in dietary assessment in Simiorekfon, Dr. Umi Fahmida, our distinguished speaker from London School of Hygiene and Tropical Medicine, Dr. Elaine Ferguson. Hello, good morning in London, yeah, Doc. Hope you're doing well. And also all the participants who follow this online lecture series in Zoom as well as in YouTube channel. Ladies and gentlemen, welcome to today online lecture series. Actually, it is the first series out of 3. And this series part of the online postgraduate training on best practices in dietary assessment held by Simiorekfon throughout this week. As the information, this postgraduate training followed by selected 36 participants across countries in Southeast Asia, which is 24 participants from Indonesia, 6 participants from Malaysia, 3 participants from Philippines, 1 participant from Brunei, 1 participant from Thailand, and 1 participant from Myanmar. The main topic of today's first online lecture series is using the nutrient references level for evaluating nutrient adequacy at the group and individual level. Before lecture start, let me tell you the rules of today's online lecture series. Please, Pak Dodi as the host, help me to screen the rules. Next slide. I'm sorry, yeah. For the rules of today online lecture series, first, the participants are expected to enter the YouTube channel on time with the link. And then the second, use the headphone is recommended. And the third, at the end of the session, participants are expected to fill out the evaluation form as the proof attendance. And fourth, the certificate will be given to the participant who completed the evaluation form. 5, the link to the evaluation form will be shared at the prior of the end session. The certificate will be available 3 weeks after this online lecture series. For further information, please visit Simiorekfon website and social media regularly. And be sure to subscribe and like Simiorekfon YouTube channel and follow other social media accounts. Next. And then write your questions in the following link of Google Form. This is the link and will be distributed also in the YouTube. And the last, the question or opinion should be brief and clear. So hopefully this is already clear, yeah, for the rules of the online lecture series today. Okay, well, ladies and gentlemen, before we start the presentation, let me briefly read the profile of our distinguished lecturer today, Dr. Elaine Ferguson. Can you slideshow, Pak Dodi? Okay. Here's the, okay, sorry. Yeah, here's the brief profile our speaker today, Dr. Elaine Ferguson. She is an associate professor at the London School of Hygiene and Tropical Medicine, London. She received her PhD from University of Guelph, Canada, and she worked as lecturer in Human Nutrition University of Queensland, Australia, yeah, University Otago, New Zealand, and before joining RSHTM in 2008. Her research interests include the evaluation of food-based intervention strategies and nutrition-related application of mathematical modeling, nutrition-sensitive agriculture, micronutrient, malnutrition, and nutritional assessment methodology. She has an interest in and commitment to strengthening nutrition programs and research capacity in low-income countries to improve maternal and child health. She has extensive research network in Asia and Sub-Saharan Africa and is currently involved in collaborative research project in Indonesia, Nepal, Pakistan, Nigeria, and Uganda. So that the brief of the profile Prof. Gibson. Sorry, Dr. Elaine. Okay, so without further ado, allow me to welcome Dr. Elaine Ferguson to give the lecture for about 15 minutes. Please, Dr. Elaine.
Okay, well, thank you very much for that introduction. I'll just, let's see, share screen. There, yeah. Well, welcome everyone. And it's wonderful to see, well, not to see, but to have so many people from so many different countries. It's a real honor to be able to talk to you a little bit today about assessing dietary adequacy. And I'll just bring this up into the slideshow. My computer seems to be a bit slow this morning. Is everybody able to see that screen?
Yes, the screen is clear.
Okay.
The slideshow, yeah.
Yes, okay. Some of the, I'll just sort of go through a little bit the steps in assessing food and nutrient intakes of individuals or populations. Usually requires a method to measure food intake, a method to convert the foods to energy and nutrient intakes. Then there's a data cleaning aspect that happens where you look at the intake distributions to see and to make sure that the data collected makes sense. So you clean the data, and then you begin to evaluate the dietary adequacy. And that's what I'll be focusing on in today's lecture.
Dr. Elaine, I'm sorry. Can you slideshow your presentation? Because
I thought that I was.
Oh, but in our Zoom or YouTube still
it's not showing.
Yes. You need to,
because it says that it's sharing. I'll try it again. I'll stop sharing and try sharing again.
Yeah. If you have difficulty, we can actually to back up you. How? Or
let's see. I'll try this again. Okay. That's strange. Sorry. Can you see it now? What I might have to do.
Sorry, Elaine. I think there is something in the bottom here. Yeah. Next. No, the other one. And two from the right. In the bottom for slideshow. Yeah, that one. No. Next to the how do you call it? The loop. Is it slideshow? Can you try?
Maybe what I'll do is I'll take it off the main screen. I wonder if that would make a difference because I've got a big screen that I look at, but maybe if I take it off
It's
that, I
double screen, yeah.
wonder if that'll make a difference. Oops. Sorry about this. I'll stop sharing again. And then I'll try sharing. Whoops. On screen. Okay, and then I'll put this, yeah, so maybe what I'll do, because I had it on a big screen, but what I'll do is I'll put it on this smaller screen. Oh, now I can't see it. So I've done something that
Already slideshow.
can you
Yes.
see it now?
Perfect.
Okay.
Yeah.
Okay, perfect. So what I'll do is I'll take it off the big screen and put it on a small screen, on my small screen. Okay, so as I said, that what I'll be focusing on today is evaluating dietary adequacy. And so what the learning objectives in today's session is really to understand the nutrient reference value system, to understand how to apply the NRVs to estimate the percentage of population at risk of inadequate nutrient intakes, including the difference between the fixed cut point approach for doing that and the probability approach. I'll touch briefly on the use of NRVs for diet counseling and how to inform the design of a fortification program or an institutional feeding program. And so in terms of evaluating dietary adequacy of populations or individuals for epidemiological purposes, that's when you're really looking at populations. So often we use dietary data to determine the percentage of the population at risk of inadequate dietary intakes of nutrients. And note that this means the risk of inadequacy. With dietary data, you can never determine whether a population or whether there is a nutrient inadequacy. You're just looking at risk, and you're not able to ever tell whether an individual has a deficiency using dietary data. Individual counseling, it's the same. It's the same point that you can't determine using dietary data whether they are inadequate, but you can use it to help ensure that they're meeting their nutrient requirements. And this will become more clear as we go through the talk. So one of the things to sort of be aware of, this is the nutrient requirement distribution. So this is looking at the range in nutrient requirements that would happen in a population. So for example, I might have a nutrient requirement that's very low, so I could be at this level. And maybe some of you might have nutrient requirements that are very high, so you could be here. And so it's just that there's, the key point here is that there is a range in nutrient requirements across people. And when we're looking at the NRVs, what we're particularly interested in is the average nutrient requirement. So this is the average for a population. We're also interested in this lower level, the lower recommended nutrient intake levels, and that would be people that have very low requirements, and also people that have very high requirements, which is what we have here, which is the recommended nutrient intake, or RDA. The other component of interest when we're looking at requirements is this upper tolerable level. And so this would be the level where if you're consuming that amount of nutrient, it would be a risk. Your nutrient intakes are too high. Not all nutrients have an upper tolerable level, but some do. And that would mean if you're consuming nutrients at that level, you would be at risk of some other component. And it depends on the nutrient what the risk would be. So those are 3 or 4 aspects within the nutrient reference values that are often referred to. And remembering this is the nutrient requirements. This is how much nutrients an individual requires to meet their needs. There's also a concept called adequate intakes. And this occurs when there isn't enough data to determine what the nutrient requirement distribution looks like. And an adequate intake is really looking at a nutrient intake level. This is for certain nutrients where we don't have the information, that would be the amount that would ensure that you were healthy. So it's not the requirement, but if you consume that amount, it should be enough to meet your needs or the population needs. The other thing to recognize is that, so this is sort of the overall sort of definitions that just are summarized in this slide. And so the thing to recognize here is that there's different terms used by different organizations. And so you can see some might use the nutrient reference values, others might use dietary reference value, and that's just the overall system. In terms of the requirements that meet the needs of the average, 50% of the individuals, you can see the estimated average requirement, the average requirement, the harmonized average requirements. All of these terms are referring to exactly the same things. And the lower intake meets the needs of 2 to 3% of individuals, but not more than that. Reference nutrient intakes, you've got the recommended dietary allowance, recommended nutrient intake, population reference nutrient intake. So again, the key thing here is that these are different terms for exactly the same thing if you're seeing it in the literature. And this just gives you an idea of the countries where these different terms are used. So the estimated average requirement, for example, is in the UK, US, New Zealand, Australia. The average requirement is by the European Union. Harmonized average requirement is just a proposed harmonization, etc. So this gives you an idea of where some of these terms are used. So the underlying assumptions for this system are that the requirements are for healthy people. So they're not requirements for people that may have a malabsorption syndrome, for example. They assume that nutrient requirements and intakes are not correlated. So energy intakes are correlated to your requirement. So we handle energy quite differently than we do nutrients, because the assumption there is, if I've got a high dietary iron requirement, for example, I'm not motivated to eat high iron foods, so that they're not correlated at all. And this is, as I said, this is why we don't use the system for energy. And there are requirements to prevent nutrient deficiencies. And in some cases, they're quite high because they're aiming to prevent chronic disease. And calcium would be an example there. And they assume the requirements for energy and other nutrients are met. So it completely ignores nutrient interactions when we're looking at these. Nutrient requirements for an individual will depend on your age, your sex, your level of physical activity. Then there's, of course, genetic variation in requirements, physiological status, such as pregnancy, because, of course, requirements go up during pregnancy, as well as your habitual food patterns, because these affect the absorption of certain nutrients or the bioavailability of certain nutrients. So if you've got a diet that's very high in animal source foods, for example, your requirement for iron will be lower because the iron is absorbed better from animal source foods as compared to plant-based foods. But as I say, and I keep emphasizing, for the individual, we do not know an individual's requirement. We just know in general for what the population requirement distribution looks like, or we estimate it. So if we're looking at these nutrient reference values, and this again is your requirement distribution, one of the steps for defining the nutrient reference values is, first of all, obtaining data that can be used to define the average physiological requirement. So that's the estimated average requirement for the target population. So that's the first step in defining an NRV, is to determine what that value is. And that's based on, different sort of experimental studies that are done, etc., to define that average requirement for the population. Then the second step is to estimate the variation in the requirement distribution for the target population. How much can we vary? Sort of what would be the lower level for individuals and what would be the higher level for individuals. then that physiological requirement has to be converted to the dietary requirement. And this is because of differences in bioavailability. You might have to consume a certain amount because, let's say, only 5% is absorbed into the body and the rest is lost. So there's a need to convert the actual physiological requirement into the biological, or into the amount that would be absorbed in the body. So iron is a good example. If you've got a low bioavailability diet, only 5% is absorbed. So the amount, the nutrient requirement then would be much, much higher than the actual physiological requirement. And then it's usually a statistical definition to determine what the recommended nutrient intake, or that level that meets the needs of 95% of the population. And that's based on an assumed variability. So these are two quite important components to define. And then finally, in terms of defining the upper tolerable limit, which, as I said, not all nutrients have an upper tolerable limit, but it really is to say this is the highest usual intake level of a nutrient that poses no adverse effects, i.e. will not, for example, compromise copper absorption or something. And it includes intakes from all sources. That would be food, water, supplements, pharmacological agents. And it's based on sort of an assessment of three terms. One is the no observed adverse effect level. And this is the highest continuing intake of a nutrient at which no observed adverse effects have been observed. And when this can't be, when there isn't data to say this is a level where there isn't any observed negative effects, the other aspect that's used is the lowest observed adverse level effect. And this is the lowest continuing intake level at which an observed effect has been observed. And then there's an uncertainty factor that's built into it. So that uncertainty factor would bring that upper tolerable limit down from where you've seen the observed effect. And that's just to make sure that that there wouldn't be anybody in the population that could be adversely affected by intake levels that high. And these are often based, they can be based on animal data, or especially when the overconsumption of the nutrient is serious. So that UL is also an important factor when we're looking at dietary intakes. So one of the things I really want you to be aware of is how challenging it is to set these nutrient requirements level, because there's very limited data and there's many factors that affect requirements that aren't necessarily taken into account. And so what you'll see is there can be differences in the nutrient requirements set in different populations. And part of that is because different decisions can be made, as well as, sort of when they were set. Most committees setting nutrient requirements would consider the age, weight, and height of their population. And for children, growth, because of course, a child that's growing more rapidly is going to have higher requirements. They usually take into account their life stages, such as pregnancy, lactation, and older people, because of course there's difference in the absorption and utilization of nutrients during pregnancy and lactation. And with age, you can get differences in absorption capacity, etc. The other important consideration is the food patterns in the population, because it can affect the absorption of nutrients. So as I've just said, in populations that have very low consumption of meat, you'll have a higher requirement because not as much is absorbed into the body of iron and zinc as compared to a population that has a very high meat consumption. So all of these are taken into account. The other thing, it's when we're looking at defining that estimated average requirement, it really, again, is based on very limited data, and it's often collected from adult males. And so for children, it's often interpolated from data based on average growth rates. So, and for lactation, it's examining the nutrients secreted in breast milk, for pregnancy amount in tissues, etc. But the key thing here is that there is a lot of uncertainty because of the limited data, and often based on adult males. For pregnant women, we often use data from non-pregnant women. For the elderly, often extrapolated from younger adults. For infants between 7 and 12 months, it's extrapolated from breast milk. And there's a limited amount of data on absorption and nutrient interactions. So the key thing here is there is uncertainties when we're setting those nutrient requirements, and that's always important to remember. And so you'll see different committees have made different decisions. And this is just giving you an example of zinc. And you can see that, for zinc, for the 19 to 30-year-olds, it's ranging from, sort of very low at 4.9 up to, 9.8, again, depending on bioavailability, etc. So different committees are making different decisions. And the reason for this difference across different committees, of course, is the date when it was developed. So in that zinc example that I just showed you, the WHO were set quite a long time ago. So that would be based on very old data. Differences in the population dietary pattern, as I said, for bioavailability. There's also differences in the subgroups, because when we're looking at these estimated average requirements or these nutrient reference values, they're based for an age range. And those age ranges differ depending on which committee. So for the UK, there's 14 different groups. The US, there's 13 different groups. And the UK has 2 different requirements for lactating women, depending on the stage of lactation, etc. So there's different decisions there. And also differences in the assumptions related to the environmental, genetic, and health and other factors. So that partially accounts for some of these differences. For some nutrients, for some age groups, there aren't enough data to be able to set requirements. And so for infants, when you're using that data, always be aware for most nutrients, it's not an actual requirement, but an adequate intake. And so that would be the intake observed in healthy infants. And as I said, often based on breast milk. So for most nutrients, it's an adequate intake. But the exceptions are protein, iron, and zinc, which actually do have that estimated average requirement. And as I said, the AIs are often based on human milk. For adults, the nutrients, there are also nutrients that are only adequate intakes because there aren't enough data to actually estimate the actual requirements in the population. And chromium and magnesium would be examples of these. And so again, they're just based on the observed intakes of people in healthy populations. And the AI, these adequate intakes, where they really should be sitting is between the recommended nutrient intake, so that's the amount that meets the needs of 95% of the population, and the upper tolerable limit. So they should be sitting somewhere here, but we don't actually know where, how close to the recommended nutrient intakes, and well enough below the UL, the upper tolerable limit, that it wouldn't cause an adverse effect. But so the key thing with these AIs is that they're not in that nutrient requirement distribution. Now, there also has been a recently published article related to harmonized nutrient reference values. And the rationale for doing this is because human physiology is essentially the same across populations, and hence the same evidence base could be used for setting requirements. It shares resources because when you're setting these NRVs, it's the cost, time, and expertise is enormous. I was involved with setting the iron nutrient requirements in Australia and New Zealand quite a few years ago now. And we probably, there was quite a few academics involved with it. And we spent over a year doing this, reviewing, the literature, looking at evidence, etc. And different individuals were responsible for different nutrients. So the resources needed to do it are enormous, and the expertise as well. And so it would also allow a basis for global comparison if we were all using the same requirements, so that, any differences in the estimated percentage of a population at risk of inadequate nutrient intakes wouldn't relate to the requirements that were used, because we're all using the same one. So that would be the other advantage of them. So they've set these harmonized nutrient requirements for 26 nutrients, which are protein, 13 vitamins, and 12 minerals. And they've got different absorption levels. They've got 3 levels for iron and 4 levels for zinc. but there's still really a lot of discussion related to these and whether they should be accepted. The other thing they've done, which is very different, is that they've calculated, so these are called harmonized average requirements. So this would be an HAR is a harmonized average requirement, and that's the requirement to meet the needs of 50% of the people. So that's that EAR that we saw in that requirement distribution. And they've actually calculated some harmonized average requirements from the AIs. And this would be, they've done this for pantothenic acid, biotin, choline, chromium fluoride, and manganese. And so they've assumed a certain coefficient of variation, and that it, based on the AIs and etc. So for some of the harmonized average requirements within this set, they're actually based on AIs rather than evidence of what the actual requirement distribution is. So just to be aware of that. So what I've just been focusing on here is where our nutrient requirements come from, because these are very important when we start to use them for estimating the percentage of a population at risk, or for diet counseling when we're trying to determine whether an individual is at risk. And so the key points here is that we do have multiple nutrient reference value levels. We've got that lower level where if you were consuming a diet that had that lower level, it'd be almost guaranteed that you weren't consuming enough of the nutrient. The estimated average requirement, and that's the amount that 50% of the population will be consuming it now, but 50% would not. Their requirements would actually be higher. The recommended nutrient intake level, and that's where if you're consuming that amount, 95% of the population, that would meet their needs. And then that upper tolerable level, where if you were when consuming that amount, you'd be at risk of an adverse effect because it's too high. And so they are used for different purposes, and they do depend on the life stage. The studies to estimate them are based, sort of on statistical definitions with an assumption in terms of the variability in the requirement distribution, which is often not known very well, but based on, and some of them, for a few nutrients, adjustments are made for inefficient use of nutrients when estimating the ER that account for bioavailability or bioconversion. So they need to know information on the diet patterns. And the key thing is that there's been limited data to estimate these physiological requirements, especially for certain age groups that are extrapolated from other age groups or sexes. And there's many factors known to affect requirements, nutrient requirements, but only a few are considered when these requirement levels have been set. So that's the nutrient requirements themselves, and they vary across countries depending on the adjustments made. There is the tolerable limit that have been defined for some nutrients, but they don't exist for all nutrients. And there now exists a proposed set of harmonized nutrient values. And in childhood, chronicle age is a good predictor of body size and growth, and thus nutrient needs. And in adults, the physiological age are important, and chronological age. So that's the nutrient requirements. I don't know if there's any questions related to no, I guess, do you want me to just continue? Because now I'm going to move on to looking at how they can be used to interpret data. Should I open it up to questions now, or should I just continue?
Let's continue first, Dr. Elaine.
Okay,
After this, we will have the discussion session.
Okay, great. Okay, so now we're going to look at how these are applied. And you've got that main point that they exist. There's lots of uncertainty, but they're the best that we have to work with, and it's our best estimates. And so now that how it's required. So looking at the different levels that we've been talking about, so that average requirement, that could be an EAR or an AR, it's the same thing. That's the amount that meets the needs of 50% of the population. That is used for individuals to assess the probability of inadequacy. It's used for groups to assess the prevalence of inadequacy. So what percentage of the population is at risk of inadequate intakes? Then we had that level, the recommended nutrient intake. That's the amount that meets the needs of 95% of the population. For an individual, that's usually your target intake level, because if you're consuming that amount, you're quite certain that your nutrient requirements will be met because it meets the needs of 95% of the people. So there's only about 2.5, sort of 5% where it wouldn't be enough. So for the individual, if you're consuming that amount, you're fairly confident that that will be meeting your needs. For epidemiological purposes, for looking at groups, that should not be used. We've got the lower reference nutrient intake level. That was the level that would only meet the needs of 2.5% of the population. For an individual, if they were consuming that amount, that definitely would not be enough because it's very, very likely it's inadequate. For population group levels, it should not be used. And the UL, the upper level of safe intake, that's an amount that if you're consuming that amount, there would be a risk of an adverse effect. So for the individual, you'd want to make sure that their usual intakes would be below that. And likewise for the population, epidemiological purposes, you'd want to make sure that the highest consumers in the population stayed below that level. So those are sort of those key levels that we've been talking about. And for meal planning, for an institution, that intake distribution within the institution, so if you've got a group of elderly people, for example, in someplace, or a group of school-age children, you'd want to make sure that the range in the nutrient intakes lay between the estimated average requirement and the UL to be sure that most individuals in that population were meeting their nutrient requirements. And I've got some more slides that'll be explaining this a bit further. So one of the concepts when we're looking at dietary intakes, whether for individuals or whether we're using for epidemiological purposes for populations, is that there is, of course, day-to-day variability in diet nutrient intakes. So on one day, you may eat a lot of carrots, for example, so your vitamin A intakes would be very high. On another day, maybe you didn't eat very much vitamin A-rich foods, so your intakes are going to be very low. So for each nutrient, there's going to be day-to-day variability. But what we're looking for is to get your usual intake, your long-term intakes, on average, meeting our estimated average requirements, or whatever your requirement is. But we don't always need information on your usual intakes because it can really be quite difficult to obtain. And so for some nutrients, you might need to collect dietary information over 30 days, for example, if there's a lot of variability, to be able to estimate the usual intakes of that nutrient for an individual. And so for an individual, if you're doing diet counseling, it's ideal to have this information on usual intakes. But if we're looking at epidemiological purposes, so for example, estimating the mean nutrient intake of a population, etc., it really depends on the objective of the study, whether we need enough to collect information over enough days to be able to estimate usual intakes. And so to do that, when we're trying to estimate nutrient intakes, we'd be collecting repeat intakes. For example, we could be doing a 24-hour diet recall over multiple days, multiple non-consecutive days, or weighed food records or estimated records if usual intakes are needed. But of course, that has huge implications for the budget and the time resources for collecting the data. And especially because the number of days depends on the population and the nutrient. As I say, something like vitamin A or calcium that's highly variable could require, sort of a month of data in order to get usual intakes. Whereas something like energy, usually 7 days are fine because it's more balanced within the food system itself. So the number of days does depend on the nutrient. One of the advantages of a food frequency is that it's compared to a 24-hour recall, is that it is trying to estimate your food intake over a longer period of time. So it is going to be better at estimating usual intakes, although there has been a debate about the accuracy of food frequency data compared to multiple days of, for example, a 24-hour recall. So what are we talking about here? So if we've got usual intake, so this is what we're looking at here now. Instead of the requirement distribution, we're looking at the nutrient distribution for an individual, for one nutrient. Let's say this could be, sort of the zinc intake, for example. If we've got usual intakes, that is reflected here in the green line. So you see that distribution is narrow. If we've got, sort of maybe 2 days, 1 day of intake, you'll see that the distribution is quite a bit wider if the intake distribution for the population is based on 1 day. And the reason is that, you may have some people, you collected the dietary data on a day they didn't consume very much food. So you've got this extreme point, or on a day that they consume more than usual. So you've got these high points. So if it's based on 1 day, that nutrient intake distribution for a population is going to be wide, as compared to if you'd collected, for example, data over 2 weeks, where you've got a better estimate of usual intake distribution, it is going to be narrow. So that's what happens looking at the intake distribution for a population, whether we have a 1 day as compared to an actual estimate of usual intake days. So when we're looking at populations, when we're looking at surveys, the need to estimate that usual intake distribution is going to depend on the objectives. And these are these 3 different levels. I don't know if you've covered this already, but level 1 is where we're looking at the mean nutrient intake of a group. In that case, usual intake is not necessary, and I'll be giving you a slide to show you why. If we're trying to look at the proportion of a population at risk of inadequate intakes of a nutrient, so the percentage of the population, for example, that has inadequate zinc intakes, usual intakes are necessary, but only for the population intake distribution, not for each individual. And again, I've got some slides to explain this. If we're looking at objectives at the level 3 or level 4 level, which is either to rank individuals, level 3, in terms of if they've low intakes, average intakes, or high intakes, then, or if we're trying to look at relationships between, for example, a nutrient intake and another outcome. So if we're trying to look at the relationship between zinc intakes and linear growth in children, then an estimate of the usual intake of each individual becomes much more important, because otherwise we get too much error that's influencing that relationship. And I've got some slides to explain this. So looking first at the average intakes of a group, why do we not need usual intakes? Going back to this slide where we've got a 1 day intake in red, we've got usual intakes in green. Our purpose is only to have the mean intake of a population. And you can see it's identical, depending on whether we've got 1 day or whether we've got, multiple days. And so it doesn't make any difference to estimate the mean of the population or the median intake of the population. We don't need usual intakes. So it's much better to have a higher number of participants than a higher number of days, because a higher number of participants is going to give us a more precise estimate of what that mean intake is. And that mean intake is not influenced at all by the distribution in the population. So it's better to have more people and less days if that's the only objective of your survey. How about if the objective of your survey is to estimate the proportion of the population at risk of inadequate intakes? Here is, well, first of all, I want to sort of alert you to an incorrect approach of how to do this. One of the incorrect approaches, which you will sometimes see in the literature, is to look at the percentage below the recommended nutrient intakes or the recommended dietary intakes. And just to remind you that RNA or RDA is the amount required to meet the needs of 95% of the population. So that's that high level when we're looking at that requirement distribution. So if we looked at the percentage of the population whose nutrient intakes lay below the RNI or RDA, that would mean that we would overestimate the percentage of the population at risk. Because there's, that's a level that meets the needs of most people. And so there'd be lots of people there that were misclassified as not meeting their needs, when actually they were meeting their needs because their nutrient requirements are less than the RDA. So if we use that approach, we'd be overestimating the problem in the population. And remember that if you're looking at the literature. And also, you know, if you're seeing something where they're comparing, this is less frequent, where they're comparing the mean or median nutrient intake of a group with the RNA, that also is not appropriate. So the correct approaches are the EAR, what's known as the EAR cut point method. And that's sort of a shortcut method. But it does make assumptions about what your requirement distribution looks like. It has to be symmetrical. It has to be a normal distribution. And then there's something called the probability approach. And this is where this has to be used if the requirement distribution is non-normal, is skewed. And I'll be going into why that is right now. So if we're using the EAR cut point approach, what you do is look at, so this is the usual intake of the population. And what it does is looks at the percentage of the individuals in that population whose nutrient intakes lie below the estimated average requirement. And just to remind you, that estimated average requirement is the amount needed that will meet the needs of 50% of the population. So half the population's requirements will be above and half will be below. And so the EAR fixed cut point says if we can get a population estimate by looking at the percentage of the population below the EAR. Reminding you again, it is only works if the nutrient requirement distribution is normal and the intakes and requirements are not correlated. And it does not identify individuals at risk. It only identifies the percentage of individuals within a population that are at risk, but not the actual individuals. And how it works and why it works. So what we're seeing here is requirements as compared to usual intakes. Anybody over here anybody in the gray line, this line is showing where the intakes equal requirements. So the gray shows individuals who are not, their intakes are not meeting their requirements, and the white shows their intakes are meeting the requirements. So that's where the individuals' intakes are less than the requirements, and this is where the individuals' intakes are greater than their requirements. Now this is looking, the estimated average requirement here is 1,200. And so if we use the EAR cut point, that's going to be defining everybody in this box as having an inadequate intake. So these are our intakes. So everybody here would be defined as having an inadequate intake. So there's our adequate intakes. But
Dr. Elaine?
Here, yeah?
Yes, I just want to remind you the presentation is 7 minutes left.
Oh dear. I'm not going to finish it in time then, sorry. I was basing it on the number of slides because I've got, yeah. Okay, I'll go as quickly as I can because I'm getting into things that are a little bit complex. Yeah. I definitely won't finish in 7 minutes, unfortunately. So what we have here is in this triangle, you see people who are classified as adequate, but they're actually inadequate because they're in that gray area. Here, we've got people that are classified as inadequate, but they are actually adequate. And what we're assuming is that these two boxes match, they cancel each other out. And that's why the EAR cut point approach will work. Now I'm going to look at why. So that is how the EAR cut point is done. So looking at why it's important to have usual intakes if you're using the EAR cut point method. As you can see here, we've got the usual intake distribution, and then if we only had 1 day of intake distribution. You can see if we had usual intake distribution, we'd be estimating maybe about 2% would be at risk of inadequate intake. But if we didn't have usual intake distribution, we only had 1 day, we'd be estimating about 20% would be at risk of inadequate intake. So we'd be overestimating the problem in the population if we only had 1 day of intake. Or if the EAR was here, it would be the opposite. So here we would be saying, sort of 98% are at risk of inadequate intake if we had usual intake distribution. But if we only had 1 day, we'd only be estimating, let's say 80% were at risk. So we'd be underestimating the percentage at risk. So this is where, not having usual intake is problematic. And this is just an example of the difference in the percentage at risk of inadequate intake, depending on the method used. So that would be the RNI would be overestimating. Percentage below the ER with a 1-day intake would also be overestimating. But if we adjusted it so it had a usual intake distribution, you'd be getting a much more accurate estimate of the percentage of the population at risk. So the other method, the full probability approach, and this is where, and this must be used if the requirement distribution is skewed. So iron requirements for menstruating women or growing children, we always have to use the probability approach. And so I'll quickly, so again, it doesn't define the individuals who are at risk, but only at the population level. The way this works is that we've got at different intake levels of iron, there's a different probability of risk of inadequate intake. So if, for example, if you had less than 15 milligrams per day of iron, it'd be 100% certain that you were inadequate, because that's, and so then if there was 2 women that had an intake at that level, all of them would be inadequate. So we'd say 2 would be the prevalence for inadequate. So you go through the intake distribution and you get up here where that the probability is almost 0, where you've got inadequate. And so at each level, you look at the number of individuals at risk, multiply it by the probability, and that will give you a number. You sum those, and that gives you the percentage at risk of inadequate intake. So this is this is sort of looking at the probability at each intake level and what that means in terms of inadequacy. But again, it doesn't identify those that are at risk. There is software that's available to generate the usual intake distribution and the percentage at risk. And I'm sure that you'll be learning how to use this software in your program. And so the PC side or IMAP can be used. And this will construct the usual intake distribution as long as you've got repeat intakes, or it can use the internal intakes. So that's looking at the proportion of the population at risk. And I'm sorry I had to rush through there. So there's 2 methods of doing it, and also some software that can help you do that adjustment so that you've got a usual intake distribution. So level 4, why do we need usual intakes? So this is looking at the trying to, for example, get a relationship between zinc intakes and growth, for example. If we only had 1 day of intake, you can see there's lots of error around that relationship. And that error is going to, what they say, attenuate that relationship. So it'll make the strength of that relationship look a lot weaker than it is. And this is just giving you another example. So let's say we had 1 day of intake, you might see quite a bit of error around the line. And so you'd be less certain that there is a relationship there. But if you had usual intakes, that's going to be much tighter. And so that relationship is going to be much stronger. And that's why if you're trying to look at relationships between a nutrient or energy intakes and another outcome, such as weight or growth, it's better to have more days of intake for each individual so that you can reduce the error that is going to be affecting that relationship and be able to better determine whether there is a relationship there. So for individual counseling, this is where you really would like information on actual nutrient requirements, but of course that's not known. So again, it's always important if you're trying to determine whether somebody is not meeting their needs is to have laboratory information, or if you're looking at energy, to have anthropometric information that would say they're gaining weight or they're losing weight, because dietary intake cannot identify adequacy because we don't know the nutrient requirements of an individual. However, there's a qualitative approach that can be used when you're counseling. So if their observed usual intake is less than the estimated average requirement, that means that there's a 50% chance that they've got inadequate intakes. Their intake likely needs to be improved because there's a 50% chance that it doesn't meet their nutrient requirements. If their usual intake is between the EAR and recommended nutrient intake, again, their intake likely needs to be improved, but it's getting less and less. The probability of inadequacy is starting to reduce. If their observed intake is at or above the recommended nutrient intake, then you'd be fairly confident that their intakes would be meeting their requirements, because the requirements, it meets the needs of 95% of the 97.5% of the population. If we're looking at institutional feeding or fortification programs, what we're wanting is our intake distribution for the target population to lie here. Because of course, if you think of the EAR cut point, this would be defining 0% of the population is at risk of inadequacy, because there's nobody falling below that EAR. But you'd also want to make sure that that intake distribution lay below the upper tolerable limit. So this is really what you're aiming for if you're doing institutional feeding or a fortification program, is to have your intake distribution lying there. Oh, this wasn't as bad as I thought. So conclusions then, the nutrient reference values are used for different purposes. The lower recommended nutrient intake levels basically aren't used very much, other than if you're doing diet counseling, because it would, if an individual's intake was at that level, you'd be almost certain that it was inadequate. So you'd be wanting to improve it. The estimated average requirement is used when we're trying to estimate the percentage of a population at risk of inadequate intake using either the EAR cut point or the probability approach. The recommended nutrient intake in ULs, if we're doing it for epidemiological purposes, we're really looking at trying to get an institutional feeding, sort of if we're feeding somebody or a fortification program where the intakes are lying between that EAR and that UL. For an individual, of course, that's giving us an idea of for an individual, we're aiming to get their intakes at the recommended nutrient intake if we're doing diet counseling. The number of days of intakes, if you're doing a survey, the number of days that you ask people to measure their nutrient intakes depends on the objectives, with a higher number of days needed if you're trying to look at relationships between dietary intake, nutrient intakes, and some other functional outcomes, such as growth. There's two methods of estimating the prevalence of inadequate intake for groups, for populations. That's the EAR cut point method, and that's a much quicker method and can be used if the requirement distribution is normally distributed, but not if it's skewed. And so iron for menstruating women or young children, you have to use the full probability approach. The desire of usual nutrient intakes depends on, so it's not too wide to avoid biased prevalence estimates. The multiple days of intake for a number of days depends on the number of nutrients. So if you're trying to look at that relationship, looking at relationships between nutrient intakes and some other outcomes, the number of days needed will depend on the nutrient. You can convert observed intakes to usual intakes using computer programs such as Seaside. And this is particularly useful if you're trying to estimate for that second objective, to estimate the percentage of the population at risk. And you should select the appropriate EAR when doing this. And for iron and zinc, that will depend on the absorption of the nutrient or the bioavailability of the nutrient. For counseling individuals, you don't know the true usual requirement, so you use a qualitative approach. And so really what you're trying to do there when counseling individuals is to have their intakes falling at approximately the recommended nutrient intakes, because then you're 97% certain that it's meeting their nutrient requirements. And if you're planning institutional diets or fortification levels, for the population, you're aiming to have their intake distribution lying between the estimated average requirement and the upper tolerable limit, because that would mean, you don't have intakes below the EAR, which would mean that you have 0% of the population at risk of inadequate intakes. And so these are just some references. And my apologies if I've gone a little over time, and my apologies for rushing it a bit at the end there. Thank you.
Thank you very much, Dr. Elaine, for giving such an important, informative, as well as the comprehensive presentation. I'm sorry, this is my impoliteness here, but actually you very great with the time. Thank you very much. And now it is time to have a discussion with our speaker. Just for your information, our participant on YouTube, the last is around 113. Yeah, that follow this lecture.
Wow.
Yes, very great. We are glad to receive so many questions actually from Google Form, and yeah, we are going to select a second two questions first, yeah, for the speaker. Now let us the question from the participant. Please, the host bring the slide on screen. Dr. Elaine, do you want to drink first? Because you already have the long presentation.
I'll bring the slides back up too, just in case there's something related to them. Okay, thanks.
Thank you. And can we continue the discussion?
Yes.
Or you need to break first? Okay, thank you. Please, the host, help me to bring the slide on the screen. Thank you.
Can you see the slides now? Oh, is it they're different slides, are they?
It is still Dr. Elaine screen, yeah. Okay. Wait. Okay, thank you. Can you make it slideshow, Pak Gusnedi? Click.
Yeah, I can see that now. Thank you very much. The key thing here is that the NRVs.
Sorry, because this is the Google PPT. I cannot show the slideshow.
The slideshow in the top, right top, Pak. Right, in the right.
Yeah. Right.
Right, the beside of.
Which one?
In the beside of bagikan, Pak.
Okay. Oh yes, sorry. Yeah.
Okay, thank you.
Okay, this is the first question. Yeah.
Well, ladies and gentlemen, the first questions come from Miss Kelly, Malaysia, asking about how do we apply the nutrient reference values of the micronutrient to individual with disease. Yeah, for example, an adult with type 2 diabetes, will they have different amount of vitamin C or E or any other vitamins and mineral given the change of body physiology? Please, Dr. Elaine.
Thank you. Yeah, thank you very much for that question, Kelly. And that's an important point, is the NRVs that we are using are for healthy individuals. So in reality, they will be underestimating the nutrient requirements of individuals with a disease. Now, I don't work as not being a dietitian. I'm not sure if there's other values available that could be used if you've got diabetic individuals. But the key point with the NRVs is that they will be underestimating the intake of individuals with diseases because they aren't, they're assuming healthy individuals. So they shouldn't be applied. But what I don't know is whether there are values that could be applied that aren't the nutrient reference values that I've been speaking about. But thank you for that question. Okay, what would be the best way to evaluate the risk of inadequacy for energy and macronutrient intakes? Are there any EARs for energy? No, there are for macronutrients for protein. And so for protein, you do have an estimated average requirement, and it's quite a well-established requirement for protein. It's one of the better, the data underlying it are stronger than some of the other nutrients. And so even the variability within the population are quite well known for protein. So protein you can. For energy, no. And the reason for that, and again, thank you very much for this question, is because our energy, the amount of energy we consume is being driven by our energy requirements. And so the best way to evaluate whether you've got inadequate energy intakes is if you're losing weight, or if you've got a very thin population, then they aren't meeting their energy requirements. Now, we do have methods of, sort of, we know the average energy requirements for a population, but we don't use what I've been speaking about to estimate the percentage at risk using it, because it's because we're assuming energy requirements are driven by it's sort of the energy intakes are driven by requirements. Now, one of the problems with dietary assessment is you can have underestimation of your actual food intake, and then you might be looking at data that looks like the energy intakes of the population are very low, and if you see the population isn't thin, then you'd be more suspicious, or you'd be more concerned that you've actually got an underestimating of their actual intake, so that rather than that their intakes are that low. So if we're looking at data, that would be two things we'd be looking at is, sort of how thin is the population as compared to, what we would expect their requirements would be, because you can use, sort of equations to estimate the requirements of individuals in a population. But what you can't do is use the EAR cut point approach that I was talking about, or the probability approach, to say that you've got a certain percentage of the individuals in the population that have inadequate intakes. And for protein, you can. For fat, again, we don't have estimated average requirements for them, or carbohydrates. Instead, we've got recommendations that, you should have, sort of 30% of your energy coming from fat, or sort of a certain percentage, but those are recommendations. It's a very different concept from what I've been talking about, where we actually are trying to predict risk. Hopefully that's clear, the way that I've described that.
Yeah, that's very detailed answer to the question. Thank you very much, Dr. Elaine. Yeah. Can we still have another questions?
Okay, related to energy adequacy. For example, we conducted a study analyzing the energy intake adequacy. Should we consider the weight of? Yes, if you're trying to determine if you've got underestimation, you'd be looking at weight, and depending on the age, there might even be a physical activity level. Definitely there is in adults, and I think for older adolescents, you take into account physical activity levels, whether or not you've got underestimation. Sorry, okay, I just had a message that my internet was unstable, so I'm hoping you can hear me okay. Yes, and so it really just comparing energy intake for this age group. Yes, so you can look at what you would expect to see. If you're underestimating it, then you're likely getting an underestimation of their actual food intakes. And I hope that's clear. So please, if what I'm saying isn't clear, just ask. Just you can pipe up and ask me as well.
Okay,
but the
last
equations
question.
are the FAO equations. Yeah, sorry?
Yeah, the last question. Yeah.
Okay, thank you.
Open mic, yeah, okay.
Yes, and so there are equations that you can, this is the same question again, and there are equations you can use that would be based on body weight, sort of whether they're adolescents, sort of 10 to 14 or over 14. If they're over 14, I think physical activity level is also taken into account, whether they're moderately active, in sedentary, or highly active. And you can get a sort of a basal metabolic intake, the Goldberg equations. I don't know if you're familiar with those, and that can give you some idea of whether you've got underreporting when you're collecting dietary data, and particularly from adolescents, because adolescents, are quite a challenging age to work with. If you're doing 24-hour recalls, they could easily be sort of misreporting, not on purpose necessarily, but just because maybe they've forgotten some of the foods that they've eaten. So it is very important when you're collecting dietary data to look at it quite critically, to make a decision on whether or not you believe that there is underreporting of their actual food intake, and then trying to determine how to accommodate that actually. Because if you've got underreporting of your food intake, so underreporting, so their energy intakes aren't meeting what you would theoretically expect the requirements to be for that population, then you're going to overestimate the percentage of the population at risk of inadequate nutrient intakes because you've underestimated their food intake. And so it just helps with the interpretation of the data to look at energy and look at whether or not it looks reasonable given, whether, especially if the adolescents aren't thin or aren't overweight, etc., then it just helps to interpret the data and to determine whether or not you might be overestimating the nutrient intake problems. And an example of that would be that we've recently done a study in Laos with adolescents where we did see that their energy intakes were, sort of about on average, sort of the average was probably about 500 or 600 kilocalories lower than what we would have expected based on their body weights. And so, it's just that then we could look at the data a little bit more critically and interpret it a little bit better. So hopefully that's clear. And if there's anything in my explanations that aren't as clear yet, please just speak up again.
Yeah. Actually, we still have a question, Dr. Elaine, from Yasmin, Malaysia. Can we share, Pak Gusnedi?
This is the last question in my slide. But
okay, thank you.
Yeah, actually, we still have time, 12 minutes. So, yeah, maybe I can read the questions. Yeah, this is from Yasmin, Malaysia. In your opinion, what form of adjustment are better for errors in dietary intake reports, Dr. Elaine?
That's a very, very difficult question. It's really, it's a very difficult question. It depends on, it would just be a matter of looking at the data and trying to, you could be comparing it to intakes that have been collected elsewhere to try to see where the underestimation may have occurred. But usually it would be partially when you're interpreting the data, because, to know that, okay, my energy intakes have been underestimated. That means that my food intake and my population isn't thin. So that probably means that we've got underreporting of the actual food intake. If you've got data that could look at food intake and see where you might be getting underreporting, maybe you could adjust, but I think the key thing there would be just to be careful with your interpretation and know that if you've got underestimation, you're going to be overestimating the percentage at risk of intakes. It's because I remember looking at data, it might have even been from the Philippines, where we saw the energy intakes of women on average was about 1,200 kilocalories, which is very low. And so there I would have expected that you'd have an underestimation. So it's reported, and it's just that when we're interpreting the data, we would know that we've probably are overestimating the percentage at risk, because it really is quite a challenging situation when you can see that happen. Yeah, and so I think it's probably comes more in the interpretation, because any adjustment of the data is also making assumptions. But I don't know if others like me, if there's any other methods that you've used when you see a high level of underreporting.
Hello, Ibu Umi.
Hello, Elaine. Thanks for asking, just sharing. So, so actually, we expect a not very high level of underreporting in our data, right? So usually when we see that there is such a huge percentage of underreporting, based on our experience, sometimes there is something wrong, systematic error in the way we estimate, for example, the portion size. For under 2 children having the formula milk, we ever experience like the dilution factor has been mistakenly calculated. So they assume the same dilution as in the package, but actually, in fact, it is lighter, more dilute, something like that. So usually when there is a huge proportions of energy under or overestimate, there is something systematic in our tool. And one of our experience is about the portion and the dilution that maybe
Yeah,
can share.
Yeah, that's a really good point, Umi. And so if you can identify where that systematic error may have occurred, then an adjustment does become possible. If it's difficult to identify, then it does become more challenging. I know in one of the recent studies we did, we actually removed the individuals that looked like they had been, where there had been underreporting, and then did the calculation again. But when we looked at the energy distribution in that case, we still saw quite a high, the energy distribution wasn't normal. So we knew that we had retained people that still had probably underreported their energy intakes. But it did give us a better estimate of the percentage at risk when we removed those who we knew for certain had underreported. And there are equations, these Goldberg equations, that you can use to do that as well. But it's a very common situation, particularly with some groups more than others. So for example, if you're doing something with the elderly and using 24-hour recalls, there might be memory errors, and so you might get underreporting there. But so there are these different methods: A, looking for systematic error, as Umi identified; B, removing at least those that you're certain are not correct using Goldberg equations, and then doing a recalculation. And always remembering when you're interpreting the data to interpret it given what you're, whether you think you've got underreporting or overreporting in your population. But thank you. And there's certain groups, yeah, thank you.
Okay, thank you very much, Dr. Elaine and Dr. Umi. And maybe we have the last questions here from the Google form. It is the question from Mary. Yeah. Yeah, from Mary Philippine. How do we assess energy? Can you also share how to assess it for different level of objective?
It's quite a different, because what I've been talking about today. Thank you for that question, Mary. Energy is very different because your energy, the amount you consume, is driven by your requirements. So everything I've spoken about today is not used, those approaches aren't used to assess energy. What we've just been talking about now is because there are equations based on body weight, age, sex, and also if you're an adult, physical activity levels that can be used to estimate the energy requirements for the population. But because we're assuming your intakes are driven by your requirements, in reality, you wouldn't expect a deficiency in the sense that you would with nutrients, because we do eat to meet our energy requirements. And that's why you don't assess it in the same way, that level 1, level 2, level 3. And what we've just been talking about is how you could use energy intakes to sort of make an estimate of whether you've got either under-reporting or over-reporting in your dietary data that you've collected. Because, as you've probably experienced so far, the collection of dietary data can be quite challenging, because if you get people, people can forget things, people can under-report, people can over-report, they can have trouble estimating portion sizes, etc. And that's why one of the advantages of looking at energy is that it does give you some insights into whether this has occurred when you collected your dietary data. But because individuals eat to meet their energy requirements, as long as you're not losing weight or gaining weight, then you're meeting your energy requirements. So it is quite different. So I'm hoping that answers that question clearly.
Yeah, thank you very much, Dr. Elaine, for the all question already answered clearly. And maybe in the last, I would like to give one opportunity to the participant in the Zoom. Actually, for the team of Dietary Survey and also FCT in Indonesia, if there are any question, we can also open mic, open or unmute your speaker. Bapak Arifin also and the team. Is there any questions? We can directly address to Dr. Elaine. Mbak Rika Rahmalina, okay.
Can I represent the participant, Dewi?
Oh, yeah, Ibu.
Yeah, actually, this is just a discussion. Maybe there is no straightforward answer, Elaine. But for some of us who are working with the OptiFood, for example, we have the FAO formula for calculating the energy requirement based on the body weight and also the physical activity level. Just your opinion, do you think this is something that for a survey to identify if energy intake is actually lower or higher than the requirement, that we calculate this formula for each individual and then compare the actual intake with this calculated energy requirement? Sometimes I'm doubtful because the actual body weight may not be ideal, right? The actual body weight of the person may be already overweight individual or underweight individual. So when we use the formula with this FAO formula, then I don't know, is it the right energy requirement, or just to would like to hear your opinion on this, Elaine?
Yeah, that's a good question, Umi. The formula itself probably doesn't. It estimates for the individual, it would be estimating their energy requirement, which actually might be slightly more or slightly less. But I think if I've understood your question, where you're coming from is if you've got an overweight population, of course, that formula is going to give you a much higher energy requirement as compared to sort of a normal weight population. And so if I'm understanding your question correctly, because there's one thing about sort of observing what energy intakes look like, and what I don't know the answer to is how well that formula works in an obese population. I'm assuming it works okay, but I don't know that literature well enough to say whether it does or whether it doesn't. So that's one thing. The second thing is, if you're trying to make recommendations, that's moving forward as opposed to observing what a population, sort of what the current situation is. Like, should we be aiming to meet their energy requirements if they're obese? And presumably, if you're making recommendations, you wouldn't necessarily want to be aiming for that. But what I can't comment on is how good that formula works when you've got an overweight population, because I don't know that literature well enough. So depending on where your question is coming from, Umi, for the OptiFood, what we're doing there is we're trying to make recommendations where we're trying to come up with food-based recommendations. So if you're using it for OptiFood, in some ways, I would probably bring it down to the average weight of the population, because if you've got high energy requirements, it's going to be much easier to meet your nutrient requirements. And so if the population was starting, so I think it would be better not to use the actual body weight in that situation. I think it would be better to use the normal body weight, because you'd want to come up with recommendations that would still provide enough nutrients to meet the needs of the population if the population had a normal body weight and were not overweight. So in the OptiFood example, I wouldn't use their actual sort of body weight at that time. I would use the normal body weight for a normal weight population of that age and sex group. So depending on sort of where your question was coming from, Umi, I'd have slightly different answers.
Thank you, Elaine. I think this energy reports in the survey, sometimes we see varied approach. Some country report like less than 70% of energy requirement, etc. So what is the most ideal way of presenting energy for a survey? Or?
Yeah, well, normally what I would do would just be to present the average energy, the estimated average, or the amount that was observed in the survey, and then somebody looking at the data and looking at, like, if you were presenting the percentage at risk of inadequate intakes of different nutrients, if you could see that the average energy intake of the population was, reasonable. So for example, if they were adult women, if it was around 2,000, then seeing that the mean energy intake of the estimated mean energy intake of the population was around 2,000, you'd have more confidence in the percentage at risk of inadequate intakes than if, for example, the mean energy intake was maybe 1,200, then you would be a little bit more cautious in interpreting the data, because it might be overestimating the problem. So just providing the mean energy intakes, I think helps to interpret the nutrient intakes, and particularly the nutrient intakes when we're looking at the percentage of the population at risk of inadequate intakes.
Thanks, Elaine. This is very important points for the participants. Thanks.
Thank you, Ibu Umi, also Dr. Elaine, for representing the FCT team in Indonesia. And Dr. Elaine, thank you very much for your presentation, and all the participants also for the questions. Actually, we have finally come to the end of the today's online lecture series. So maybe I would like to remind everyone, please fill out the link of the evaluation form as requirement to get the certificate. And okay, we will be seeing you again second OLS or lecture series still with Dr. Elaine later on 19 May 2022 with the title Choosing and Modifying Food Composition Table or FCT. So on behalf of the committee, I would like to say thank you very much, and I'm sorry if any mistaken of the lecture. So see you all later, and thank you, Dr. Elaine. Please maybe still stay here, yeah, Doc. Can we make photo session first, maybe? Yeah, as the documentation. Pak Dodi or Mbak Afifah maybe can help us to take the together with Dr. Elaine.
Yeah, okay. 1, 2, 3. One more again. Hmm. 1, 2, 3. Okay, thank you.
Thank you, Mbak Afifah, to help, and we can continue the lecture, Dr. Elaine. Or we have the breakout room for Dr. Elaine, Mbak Afifah. Or Mbak Laras. Still mute. Is there any, yeah. Oh, okay. Okay, Dr. Elaine, thank you very much for your presentation as well as your attendance here. Maybe we will continue the online lectures again at 19 May 2022. So after this, we can see you again. Yeah, thank you very much. And maybe if you have any other business, you can also leave this Zoom. Thank you very much.
Okay. Okay, well, thank you very much. And we'll see you again on Tuesday. Yeah. Bye-bye.
Thank you, Elaine.
Yeah.
Have a good
Bye.
day.
Okay. Pak Dodi, it is still stream on YouTube or not? Yeah, because we will continue the lecture today. I mean the session of the breakout room. Yeah, in my computer still there is notification live, yeah, on YouTube.